תכף. היי, ערב טוב לכולם. We're starting. כיף שאתם כאן איתנו בסדרת הוובינרים שלנו לרגל חודש המודעות לתסמונת אהלרס-דנלוס. אנחנו כאן היום בוובינר על ניהול כאב וטיפול בכאב ב-LDN, שהיא תרופה חדשנית יחסית, נלטרקסון במינון נמוך, ויעביר את הוובינר דוקטור פרדיפ צ'ופרה. אני הילה וייס, מנכ"לית ומייסדת שותפה של עמותת אגם, ונמצאת איתי כאן עינת פרי, שהיא חברת הקהילה שלנו, ודוקטור צ'ופרה הוא רופא מומחה לכאב עם עניין מיוחד במצבי כאב כרוני מורכבים. הוא מוסמך מטעם ארגון הבורד האמריקאי ברפואת כאב ובהרדמה. הוא פרופסור חבר בבית הספר לרפואה של אוניברסיטת בראון ברוד איילנד ובפקולטה לרפואה באוניברסיטת בוסטון, וכמו כן הוא גם חבר בצוות המחקר והטיפול בניהול כאב של עמותת אהלרס-דנלוס העולמית, וגם חבר בקרן המחקר על LDN. מי שצופים בנו עכשיו דרך ממשק הלייב, אז כרגיל אתם תוכלו להעביר שאלות, לכתוב אותם בתגובות ללייב, וחלק מהן יקבלו מענה בסוף הוובינר. מי שיכול ויכולה, תכתבו את השאלה שלכם באנגלית, וכמובן אנחנו לא נוכל, פרופסור דוקטור צ'ופרה לא יוכל לענות על שאלות שמצריכות היכרות עם הרקע הרפואי שלכם. אני אעבור עכשיו לאנגלית. So good evening everybody. We're happy to have you here on our live webinar series for the Awareness Month for Ehlers-Danlos Syndrome. I'm Hila Weiss, I'm CEO and co-founder of Agam, the Israeli EDS Society, and also here with me is Einat Peri, a member of our community. We're very excited to have Dr. Pradeep Chopra here tonight, who will talk about pain management and low-dose Naltrexone treatment in EDS and hypermobility spectrum disorders. Dr. Chopra is a pain medicine specialist with a special interest in complex chronic pain conditions. He is board certified in pain management and anesthesiology. He is an assistant professor at Brown University Medical School and at the Boston University Medical School. He is a member of the Pain Management Working Group of the International Consortium of the Ehlers-Danlos Society, and he is also a member of the Low-dose Naltrexone Research Trust. Thank you so much, Dr. Pradeep Chopra, for being here with us tonight. And the floor is yours. You can start your presentation and share your screen.
All right. Can you see my screen?
Yes.
All right. Thank you very much for that introduction. It is such an honor and a pleasure to be over here with you. I know I can't see you, but I'm sure you're all there. The goal for today is that I'm going to talk about managing complex pain in patients with Ehlers-Danlos syndromes. This is not a very, very detailed presentation, mostly because it takes a very long time and we don't have that much of an attention span. But I'm going to explain to you what the issues with pain in EDS is and what are the other issues that come with it. And we'll talk about all of those. All right. So this is just a standard disclaimer. I don't have any conflict of interest. No one's paying me, or I'm not trying to sell anything. I might talk about off-label use of medications. And this is just for your information purposes. This is not meant to be a treatment, not a recommendation for treatment. This discussion is for your information, but you should talk to your physicians about any treatments. This you already know. I'm a pain medicine specialist with a very special interest in complex pain conditions, of which EDS is one of them. I did my training at the Harvard Medical School, both in anesthesia, critical care, and pain medicine. And now I teach at the Brown Medical School, and I also practice. I'm on a bunch of medical advisory boards, all of them are actually nonprofit organizations. And so let's start with the real thing over here. So what are the general concepts of managing pain in EDS? There are three things to remember when you talk about managing pain in EDS. One is that patients with EDS have weak connective tissue, and what happens is the human body is like, think of the human body as a skeleton, and everything is connected to the skeleton. Muscles, ligaments, tendons are all connected to the skeleton, and that tissue that connects it is called connective tissue. The difference between me and a person with EDS is that my connective tissue is tough, whereas a person with EDS, the connective tissue is more soft. That is the only difference. EDS is not a disease. It's just a form of the human body. Like there are tall people, short people, black people, white people. They have their own sets of conditions, and that's because they have different forms. And same thing with EDS. Your tissue is softer, and that is why there are issues with that. The other problem with EDS is called proprioception, a poor joint position sense, and I'll talk to you about that later on in more detail. It does come with other medical conditions such as dysautonomia and mast cell activation syndrome, and I'll talk a little bit about that to connect the dots. Now, with any condition, especially pain, it is really important to understand what's broken, and to fix what's broken, that's the main thing. If someone has pain for any reason, it is really important to find out what is the source of the pain. And once you find the source of the pain, fixing it is the only treatment. Everything else is a Band-Aid. For example, if someone has shoulder joint pain in EDS, it could be from a dislocated shoulder joint, or it could be spasms of muscles around the shoulder joint, or it could be a nerve or blood vessels that are being pinched, or it could be all three of them. So the treatment of this shoulder joint pain would depend on the reason, whether it's a dislocated shoulder joint, or whether it's muscle spasms, or whether it's a nerve which is being pinched. Now, when it comes to treatment of pain, there is no one solution. You have to use a mix of solutions. For example, if someone has knee pain due to instability, then you try to stabilize the knee with braces, you try to strengthen the muscles around the knee, and then you can use some medications to help with the knee pain. I call this the NC10 rule, in which it means that you can get 10% from one thing, say for example, 10% from stabilizing the knee, 10% from strengthening the muscles, 10% from physical therapy, 10% from using some medicines. So if you have 5 of these 10% things, you wind up having 50% relief. And that is what is called, is what we use, what I call as the NC10 rule. So don't look for one magical solution. Look for different solutions, each of which will help you a little bit. So let's talk about tissue injury in EDS. It's not just EDS. We all have something called micro trauma. For example, if I get up from my chair and I go for a walk down the block, then there is some tissue in my body that is being damaged. It is invisible, it is micro trauma, I don't see it. The problem is, the thing in my case is, because my tissue is stronger, it heals very quickly, and I don't break down as much tissue, and the tissue heals down faster. In patients with EDS, because the tissue is softer and a little weaker, there is much more tissue trauma and micro trauma. And it also takes longer to heal. For example, vacuuming, chopping food, dusting, these are all repetitive uses. And when you do these things, there is micro trauma with each of them. So you have to, what I'm trying to say is that to prevent this micro trauma, you have to pace yourself. You cannot do 2 hours of vacuuming, do 15 minutes of vacuuming, then go do something else, come back after an hour and do a little bit of vacuuming more. So to avoid too much micro trauma, you have to pace yourself and break down your job, your work. Macro trauma is easy. We know that, for example, in this picture, in this X-ray, you can see that there are bones that are dislocated, there are bones that are fractured. That is not, anybody can diagnose that, and it's not a problem. it is a problem in EDS, joints get subluxed and all that, but the bigger problem in EDS is actually the micro trauma that happens on a daily basis. And here's another picture I wanted to show you. And as you can see in this elbow muscles, you can see how there's a small break in the tissue from repetitively using your arm. And this tissue breaks on just from a very simple maneuver, like say, for example, chopping onions. And then the second problem is that it takes much longer to heal, which means that you have to give it time to heal, which means that you have to pace yourself. This is another example. Let me see if I can pull up a pen. This is normal tissue over here that you see. And on this picture, you can see micro trauma, and you can see the difference, how the picture on the left is such healthy muscle that you can see. Whereas on the right, you can see how the tissue has been damaged so much that the fibers are all in a disarray, they are disorganized. Same thing in this picture below, you can see a tendon and how part of the tendon has been damaged, not the whole tendon. And again, in EDS, I just want to stress again, this tissue breaks down very easily. The second problem is it takes much longer to heal. So this is just to recap again, macro trauma is easy to find. You sublux a shoulder joint, everybody knows that, it's easy. You put it back, it's gone. You break a bone, you put a plaster cast, it's fixed. But it is the daily problems that we have with micro trauma that we don't see. And that is what you need to avoid. And the best way to avoid it is to pace yourself very carefully. So one of the things I want to do is I want to discuss problems in EDS by body regions. So let's start with the head and neck. Headaches. There are actually 16 reasons for having headaches in EDS. And I've taken out the more rare conditions and I've just put in the more common conditions. And the first one is migraines. Now, I don't know if migraines is more common in EDS or not, but migraines are more common in women, and women have more EDS issues. So that's one of the things. Chiari malformation is another reason for having severe headaches. Cervicogenic headaches are headaches that come from the muscles, and I'll talk a little bit more about that. Temporomandibular joint dysfunction, that's the jawbone. Blurry vision is another reason for having headaches. Obviously, if you have blurry vision, then you try to focus more, you move your head forward, and that gives you a headache. Why would somebody have blurry vision in EDS? From POTS. POTS can cause blurry vision. POTS is another reason, or dysautonomia is another reason for having headaches. Most often these patients, when they stand, they get a headache. When they lie down, it gets better. It doesn't go away, but it gets better. Tethered cord syndrome, we'll talk more about this, has been known to cause headaches. Spontaneous CSF leak can cause headaches. This causes a low pressure inside the head. And because of the low pressure inside the head, they have a headache. Craniocervical instability, where the head and neck, where the neck is unstable, the spine is unstable, and that contributes to headaches. And then, of course, intracranial hypertension, where the pressure inside the head is high, and that can cause headaches. Intracranial hypertension can happen in Chiari malformation also at the same time. So patients with Chiari malformation can also present with intracranial hypertension. And then some patients can present with intracranial hypertension without Chiari malformation. So going a little more into details with headaches, my whole head hurts. I see double and I can feel my heartbeat in my ears. So my whole head hurts, and my vision, I can see double, and I can hear a heartbeat in my, like, beating sensation in my ears. This is a symptom of idiopathic intracranial hypertension. What that means is that these patients have high pressure inside their head. It used to be known as pseudotumor cerebri. It's not used as much, that term. It's because it's not a tumor and people were freaking out. So it's more of a hypertension. the pressure inside the head is high. Because the pressure inside the head is high, they also have double vision. They have vision issues. They are sensitivity to light. They have pulsatile tinnitus. That means the ringing in the ears goes along with their pulse. So it goes boop, 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 boop. Oftentimes, it is because of narrowing of blood vessels inside their brain. So blood flows into the brain and blood flows out. And what flows in has to flow out. It is an equal balance. But if the blood flowing into the brain is higher and the blood flow out is not as much, so the pressure starts to build up inside the head. Another reason I did not mention in this case is in Chiari malformation, there is an increase in the CSF pressure in these patients, and they present with headaches also. And it's a very intense pressure headache, these patients. Oftentimes, the headache gets worse when they cough or sneeze, and they'll notice that they get this sharp shooting pain in their head when they cough. The standard diagnosis is by doing a spinal tap. We don't recommend doing a spinal tap in EDS because oftentimes, number one, they wind up with having a postdural puncture headache. Number two, because the dura mater is softer, the pressure measurements with a spinal tap are not accurate. Eye exam can also show changes in eye because the pressure inside the head increases. It puts pressure on the optic nerve. And so you can see changes in the eye. I don't recommend that I don't recommend basing the diagnosis on an eye exam because by the time the eye exam shows up, it's too late. So I've had patients come back here where they have told me that their doctor said, oh, well, your eye exam was normal, therefore you can't have hypertension. And that is a bad idea because by the time the eye changes happen, it's too late. The best one is to do an MR venography where they look at the blood flow inside the brain. Treatment for hypertension in the head is there are medicines that can decrease the fluid pressure. They can do what is called a VP shunt, ventriculoperitoneal shunt. It is a little tube that they put in the brain and that kind of drains the fluid out. Or if there is, because of a narrowing of a vein, they use a stent. Another symptom is my headache gets worse when I stand and it almost goes away when I lie down. So I want you to remember this. It gets worse when they stand, but it goes away when they lie down. And that is a symptom of spontaneous CSF leak, also known as intracranial hypotension. That means low pressure in the head. So this is a weird picture, but I just want to show you there is a fluid around the brain, and this fluid flows around the brain. It flows into the spine, and then it flows back into the brain. So it's a closed system. The fluid is not going anywhere. It just keeps recirculating. But what if there is a leak over here? If there is a leak over here, if there's a leak somewhere here, the CSF is going to come leaking out. And when it leaks out, the pressure inside the head begins to drop. And when it begins to drop, they develop a headache. It's called a low pressure headache. And obviously when they stand, the brain settles down and they feel this kind of intense headache. And it actually, when they lie down, it goes away completely. It becomes zero. I just want to differentiate this. It also happens in POTS. People with POTS, when they stand, the headache gets worse, and when they lie down, it gets better. But the difference is that in POTS, the headache does not go away. It just gets a little better. But in CSF leak headache, the headache goes away completely. Normally, what I ask my patients is, does the headache get better by 50%? If it gets better than 50%, by 50% at least, then I think of a CSF leak headache. Now, so here's the problem. There's a high pressure headache and then there's a low pressure headache. Sometimes, so when someone has a CSF leak headache, we tend to think that the pressure inside the head is low. But it can also be possible that the pressure inside the head is low, and that is why they have developed a leak, almost like a pressure release. And the leak is happening because the body is trying to lower the pressure inside the head. So one has to, when someone presents with a CSF leak headache, they have to look for both a high, it could be because of a high pressure, or it could be because of a low pressure. Let me explain this concept again. When someone comes with a low pressure headache because there is a CSF leak, then it is possible that they may have a high pressure inside their head, and that high pressure is causing a leak. And because of that, they develop, they go the opposite way. Now they have a low pressure headache. But the problem, the real problem is that their pressure inside their head is high. So doctors who treat CSF leak headaches also look for high pressure inside the head at the same time. So another symptom that they come with is, my headache gets worse when I cough. I have tingling in my hands and I have difficulty swallowing. So when I cough, my headache gets really worse. And then I have this tingling that happens in my hands and feet. And then when I swallow, it feels like I'm choking. This is a symptom of Chiari malformation. Let me show you what Chiari malformation is. On this left side is what you see is a normal picture of a normal brain. And this line over here is the opening below the skull. There's a hole at the bottom of the skull. The brain becomes a spinal cord over here. And at the back of the brain is this cauliflower looking substance. It's called cerebellum. And this cerebellum is responsible for balance and coordination. This part of the brain is called the brainstem that goes through the hole, is called the brainstem. And that is responsible for some vital functions like maintaining your blood pressure, breathing, some automatic functions. What happens in Chiari malformation is, for whatever reason, it's too detailed to go in right now, but what happens is the brain starts pushing down through that hole, and that hole becomes tight. Everything gets plugged into that hole. So now the cerebellum is pushing through that hole, and the brainstem is also pushing through that hole, and everything gets jammed together. So these patients will then develop symptoms of poor coordination. They develop symptoms of difficulty swallowing. They have symptoms of breathing. They have difficulty maintaining their blood pressure and heart rate. But the other problem is that there is a fluid around the brain that flows. It's called the CSF. This fluid flows around the brain. And then it comes down into this hole and it goes down. But because the brain is plugged into the hole, so it's plugging it in there, this fluid cannot go anywhere. It is stuck inside. And slowly the fluid pressure inside the brain starts to increase. So patients with Chiari malformation can present with symptoms of increased intracranial hypertension. And that is why when they cough, the pressure inside the head increases and they feel this intense pain in their head. These are some of the symptoms of Chiari malformation. The one in the red are the more common features. So they have neck pain, they have balance problems. I told you, because the cerebellum is getting stuck. They have tingling in their hands and feet. They have dizziness. They have difficulty swallowing. They have poor hand coordination. And most importantly, their headaches get worse with coughing or straining. How do you diagnose Chiari malformation in EDS? Here's the difference. Diagnosing Chiari malformation in EDS is different from diagnosing Chiari malformation in patients without EDS. In EDS, they need an upright MRI of the neck. What happens is that there is something called cranial settling, which means that the head sort of, because the ligaments are loose, this whole skull sort of settles down when they're upright. And that's why an upright MRI of the neck has to be done. Unfortunately, there are not too many centers, even in the United States, there are not too many centers that do upright MRIs. I'm not sure about Israel. But getting a good history and physical examination should make a doctor think about Chiari malformation. And these are the symptoms I just mentioned. This is to show you what I mean by why it's important to have an upright MRI. So the picture on the left, oh my God, I don't know how I did that. Give me 1 second. Anyway, the picture on the left is a supine MRI. This is a patient that is lying down like a regular MRI. And this part over here is approximately where the hole is under the skull. And you can see nothing is poking through that, and the hole is pretty wide open. This MRI on the right is a sitting MRI. This is a sitting MRI or an upright MRI. And here you can see that the hole is jam-packed. Everything in that hole is jam-packed. The cerebellum is stuck in there. The brainstem is being compressed. And that's the reason why we look for an upright MRI in patients with EDS. But I just want to stress that if there is no upright MRI available, it's not the end of the world. A lot of it is clinical symptoms that can also give us physician an idea that this might be Chiari malformation because there are enough symptoms that I talked about. This is more of neck pain where my head feels too heavy to hold up. So oftentimes patients will say, you know, by the second half of the day, it feels my head is too heavy to hold up. They wind up sitting like this with their hand on their chin, or they're resting their head on the back of a chair. This is usually because of something called craniocervical instability. So we know that the spine is stabilized by ligaments. And we know that in EDS, these ligaments are made of elastic bands. They are not like ropes. These ligaments are very lax. So the spine becomes unstable, and that instability of the neck makes the head feel heavier. So the usual head weighs the same as a bowling ball. It's about 11 pounds. And so it's balanced. So the head is balanced on this pen. So it's balanced on the neck like this, and that's the head. And the head weighs about 11 pounds. So it's like a bowling ball. Now, normally in my case, for example, this head is nicely held together by ligaments. So it's tethered down by ligaments. So as I'm sitting here, I'm not using any muscles. My ligaments are holding my head in place. In EDS, these ligaments are made of bungee cords. They are like elastic bands. So the head tends to roll off. And to prevent that from rolling off, the muscles in the neck try to hold the head in place. So as I'm sitting here, I'm not using a single muscle in my neck. My ligaments are holding my head. But as a patient with EDS is sitting, they can't depend on their ligaments. So their muscles are working extremely hard to hold their head in place. And that's called craniocervical instability. This is what I wanted to show you, what a craniocervical instability in an EDS patient looks like. The top picture is a neutral position. And you can see there's really not much compression over here. But when they extend their head, so when they put their head backwards, you can see how significantly the spinal cord is getting compressed. And that's what you see in craniocervical instability. That's the problem with craniocervical instability. So patients with CCI or craniocervical instability present with obviously neck pain. They present with headaches, dizziness, they have tingling in their face, fatigue, poor sleep, they're ringing in their ears, and they have nausea. Generally, their head starts to feel heavier by the end of the day. But I wanted to point out that a lot of these symptoms overlap with other conditions. For example, if someone has neck pain, that could be from another reason. It could be just neck pain. The muscles are tired. Headaches could be from just migraines and nothing else. And so they would feel, headaches could be just from migraines. And so it doesn't have to be always something like CCI. So the imaging for CCI is, you need functional imaging for this. Static pictures are not helpful. We need functional imaging where you have the patient flex their head, you have them turn their head to one side, you have them turn their head to another side, and they then look at the movement of the vertebra in this. Another way to do that is to do what is called a DMX, or digital motion X-ray. That is what, again, a dynamic MRI looks like, and you can see the difference between a neutral position, flexion, and extension. Now, can you get me some liquid IV? Now, this slide shows different angles that need to be measured. I'm not going to go into too many details, but usually neurosurgeons would like to look at these angles. Sometimes the radiologist can measure them, or sometimes the neurosurgeon himself or herself will measure them, and they're called these are called the clavoaxial angle, Harris measurement, or the Grab-Oakstone measurement. I put that there in case you wanted to, for any physicians in the group. So the management of, how do you manage craniocervical instability? Give me one, can you excuse me for 1 second?
Yes, of course.
Sorry. So for mild to moderate cases, you you can start with strengthening the neck muscles. You can use a hard cervical collar, and I'll show you some. But in severe instability, if you have an instability like this one, then you have to think of you'll have to think of a cervical fusion. This is called the Vista multi-post therapy collar. This is one of my favorite ones. It supports the head over the neck. It has a little air pocket inside, so it sort of adjusts to the face. That's one you can use. This one is another one. It's called the Miami J collar. This one puts pressure on the front of the chest, not on the collarbone. This is also a very popular one. I don't really recommend soft collars for real CCI, but in patients who have some weakness of their neck muscles, I do recommend using a soft collar. The problem with soft collars is that they change shape easily. And so they can use either a soft collar like this, or sometimes if they have issues, they can use an airline pillow. Make sure it's an inflatable neck pillow that they can use. Pain from rib subluxations. This is a horrible pain. And that's the reason why I put it there, where the rib subluxes, and it is an excruciating pain. Usually these ribs will sublux in the back, in the thoracic region. So I wanted to show you why it happens. This over here is the spine. Forget the front, look at the back. This is the thoracic spine. And all ribs come and connect to the thoracic spine. So you can see over here, they're connected here. That's the back portion, that's the spine, that's the front portion. And all ribs connect to the spine in the back, and they make 3 joints. And joints in EDS are not usually very stable, so they tend to sublux. And that's where the rib subluxes. And when it subluxes, then it causes excruciating pain because it's out of place. The reason it can sublux is that, remember, this is the spine, right? And if the spine, I don't know if you can see my finger, if the spine bends, then these ribs start to pop out. So if the spine bends, then the rib pops out of place. So this rib comes out this way. And when it comes out, the muscles around it go into a spasm. It causes excruciating pain. And that's the reason why they do it. So the treatment, so like, remember I told you the treatment for anything, for pain in EDS is to find out the cause of the pain. So in this case, the cause of the pain is the spine flexing. And usually EDSers tend to flex their thoracic spine a lot. And when they flex their spine a lot, then the ribs start to sublux. The treatment for that is not a fun treatment. This is not just for rib subluxation, but for also stabilizing the hip and all that. But I wanted to show you, this is a British company called DM Orthotics, and they design clothing specially for EDSers. And this would be one of the things, or something similar to that, where it supports the torso or the spine. It gives it a good support. And that would help prevent your spine from flexing too much. Another one is this one. This is not a medical device. This is a company called Leonisa. They make something called shapewear. And actually, there are other companies that make shapewear also. And what this does is it holds the spine together. And you can see, I don't know if you can see, these are bands over here. And then there's a zip over here, which really keeps this torso together. It's supposed to make you look slim and trim, but it does help patients with maintaining their thoracic spine, so it avoids rib subluxations. Let's talk about numbing medicine before I forget. As you probably know, that most patients with, I'm sorry, this is a mistake, do not respond to lidocaine. And what we found out is that there are certain local anesthetics like carbocaine or bupivacaine that can work well in EDS. So if next time you're having a dental procedure done or some sort of a numbing medicine being used somewhere, ask your doctor to use either carbocaine or bupivacaine. They're both commonly available. So let me talk to you about another spinal condition called tethered cord syndrome. Excuse me, this is not a rare condition. It's a very common condition in patients with EDS. Actually, I should say it is very commonly missed in EDS. And I wanted to bring to your attention because this can have long-term implications. So oftentimes these patients present with low back pain. There's no other reason for having pain. There's nothing going on in the back, but they still have back pain. They have something called neurogenic bladder, which I'll explain to you. They have leg weakness. The weakness becomes, their legs become weaker as they walk. So oftentimes you'll notice that their gait starts to change. Their legs start to get weaker as they walk. They have cramping pain in their legs, what we call as Charlie horse. In the calf muscles, the gastrocnemius muscles, they start to cramp. This is a picture of the tethered cord, and on this side you can see it's a normal spine. If you took the spine and you cut it in half, you would see that. The normal spinal cord ends at L1, which is about the height, about your mid-back. In women, I generally say it's about this place where your bra ends. So it's pretty high up. And then after L1, there is nothing. It's just a cord. It's just a thread hanging down loose. It's called phylum. It just hangs loosely over there. And the reason it hangs loosely is because as kids grow taller, as we use our back, everything moves along. The brain, the spinal cord moves along. It's not being yanked. In tethered cord syndrome, the spinal cord, the phylum, that phylum down here is stuck to the coccyx bone or the sacral bone. It is stuck there. So now the whole spinal cord is under tension and it's being pulled. So you can see how the spinal cord ends over here at L1, but over here it's now ending at L3. The problem with that is that it's yanking on the entire spinal cord. And so these patients present with all sorts of neurological problems. Like I told you over here, they have aching, burning pain in their lower back, legs, weakness in their legs. Their legs feel heavy as they walk. Sometimes they have toe walking or heel walking, usually in kids. This is a congenital condition. It's not just particular in EDS, it is common in other conditions, but it so happens that it shows up a lot in EDS. I mentioned neurogenic bladder, and I wanted to show you what exactly I mean by neurogenic bladder. A neurogenic bladder means that patients have urinary hesitancy. That means they have difficulty starting. They go often, mostly, but there are some cases where they hardly go at all. They get a sense of urgency, like I can't wait, I can't wait, I need to run. But most commonly that I see is that they have difficulty emptying their bladder. So they're sitting on the toilet, they just peed, and they're not sure if they should get up or not. And like, they're not sure. It looks like they have some urine left. And so they wait a little bit longer, or they'll get up and go out and then go right back to the bathroom again. And that's the sense of incomplete emptying of the bladder. These symptoms are called neurogenic bladder. In some cases, they may even have incontinence. Here's the problem. MRIs are not useful for diagnosis of tethered cord syndrome. It has to be, the reason is that in MRIs, they look for thickening of this phylum. And the thickening of the phylum happens very late in life. By that time, a lot of damage has been done. And so it's very rare that it'll show up on an MRI. Neurosurgeons around the world are divided on this. Some claim that if it is not an MRI, it does not exist. And some claim that you don't really need an MRI. Oftentimes, neurosurgeons who understand EDS well know this very well. When you talk to a neuroradiologist, they always say that an MRI is not useful for diagnosing tethered cord. But the only reason you may want an MRI is to rule out any other problems. Is there something else that's causing all of these issues? Surgeons will often look for something called a urodynamic study. They look at the bladder to make sure that if these patients actually have a neurogenic bladder. Here's the problem. We talked about Chiari malformation. We talked about tethered cord. About 70% of patients who have Chiari malformation also have tethered cord syndrome. So as a rule, whenever I see a patient with tethered cord syndrome, I also look for Chiari malformation. If I see a patient with Chiari malformation, I also check for tethered cord. They usually go hand in hand together. Let's talk about belly pain. So in belly pain, abdominal pain, extremely common in EDS. It's a really big problem. I mean, I have about a database of over 1,200 patients with EDS that I have seen so far. And I think almost 80% of them have GI issues. And the GI issues can be anything from gastroparesis, which is slowing down the stomach. POTS can cause GI issues. It causes nausea, acid reflux, bloating, constipation. Mast cell activation syndrome, which we'll talk about later on, can also cause acid reflux, which is belly pain again. Something called SIBO, small intestinal bacterial overgrowth, can happen. It usually happens in patients with gastroparesis. There's something called ACNES, anterior cutaneous nerve entrapment syndrome. It's a little difficult for me to, because of time, it'll be a little more difficult to explain this, but I'll be happy to do it at some other time. But generally, in this case, what happens is that the nerve that goes into the abdomen on the outside, when it goes in there, it gets squeezed. And when it gets squeezed, these people have excruciating pain. Mast cell activation syndrome can cause GI issues, severe GI issues, actually. They cause severe GI pain. So I'll discuss mast cell activation syndrome later on, but let me explain what happens in mast cell activation syndrome is that the lining of the intestine becomes inflamed. The GI tract is, the intestines are very, very sensitive. If they get inflamed, they stop working. So think of your intestine as a long tube. And when you eat food, it gets pushed along like a toothpaste. If the lining of the intestine gets inflamed, then the intestine stops moving. It's not pushing the food anymore. That food, that breakfast you had this morning is still sitting there, and now it's getting fermented and bloating and causes all sorts of pain. Proptosis is your intestine dropping down. It's not usually a painful condition. Hernias are very common. Another painful condition is called median arcuate ligament syndrome, also called MALS. Now, I want to tell you this. It's not documented in the literature that MALS is common in EDS, but in the last 4 or 5 years, people who treat EDS in the United States are seeing more and more cases of MALS in patients with EDS, and we are not quite sure what's going on here. So no research has been done on it yet, but we are starting to see a higher incidence of MALS in patients with EDS. So mast cells can cause inflammation of the intestine. They also cause inflammation of the bladder, and oftentimes these patients present with inflammation of the bladder also. And some of the symptoms they call it causes distension, nausea, diarrhea, alternating diarrhea or constipation. Let me talk a little bit about MALS. The symptoms of MALS, these patients develop instant pain after eating food, almost immediately. And the pain is pretty much in the upper abdomen, or called the epigastric region. It's in the upper abdomen. It's a really excruciating pain that they feel. They get tiredness after having a meal. They get very sleepy. Any activity or exercise can increase the pain. They may have diarrhea, not as much. The pain increases with being upright, but it gets better when they lie on their side. So what happens in MALS is on the left, you have a picture I wanted to show you. This is where they have the pain. This is the epigastric region where they have this pain. Essentially, this is a complicated picture, but well, there's a website called MALS Awareness, and that'll give you some information. But what happens is this is a ligament, and this ligament compresses an artery that supplies blood to the intestines. So when it when it compresses the artery that goes to the intestine, the blood flow to the intestine becomes less. And when it becomes less, the intestine becomes painful. It also compresses nerves that are over here. So they have both nerve pain and ischemic pain. The treatment for, the diagnosis of MALS is usually there's a screening test is a duplex ultrasonography. So they can do a sonography of the celiac artery and see how the blood flow changes when they're standing, when they're lying down. or when they breathe in or breathe out. But to get a more confirmed diagnosis, you need a CT scan angiography. Unfortunately, the treatment is surgical. Fortunately, the treatment is amazing. We've seen there are a few surgeons who do treat males, and the treatment is excellent. The results of the surgery are excellent. This is called the low FODMAP diet. I don't want you to read all this right now, but I put it in there so you can read it later on. But anecdotally, it has been shown that a low FODMAP diet is very, very helpful in patients with EDS, with GI issues. So you'll hear this term a lot, subluxations and dislocations. And I wanted to explain to you what that means and what are the issues from that. In a subluxation, most EDSers have subluxations. They don't have dislocations as much. They do, but they're not, but subluxations are a lot more common. So imagine this is a joint, okay? All joints are two bones. In a subluxation, the joint slips out and then slips right back in. What a patient with EDS would feel is when it slips out, something does not feel right. Something is out of place and it's very painful. And then they do a little adjustment and then it slips right back in and everything is, the world is nice and beautiful. The joint goes back in, everything feels like it's in the right place and the pain subsides. And this usually happens because the ligament or the capsule is overstretched. In dislocation, the bone comes out and it stays outside, and then you need help to put it back in. This usually happens when the capsule is torn. And that's why we don't see this often, because generally in EDS, because our ligaments are so stretchy, they don't tear as often, but rather stretch a lot more. So what happens is when a joint subluxes or dislocates, the pain is not from the joint itself. The pain is usually from the muscles around the joint. For example, if my shoulder joint subluxes or dislocates, then the rotator cuff muscles around my shoulder joint, they tighten up, almost trying to hold my joint in place. And that's what causes the most pain. The reason why I'm saying this is because a patient may go for treatment and they say that, oh, you've got pain because your muscles are all tight here, but your muscles are tight because they're trying to keep your shoulder in place. And then the therapist or the doctor, whoever, tries to loosen up the muscle. And when they loosen up the muscle, the shoulder starts to dislocate even more or sublux even more. So the treatment is not treating the muscles, but treating the joint itself. Give you an example. Look at this shoulder joint. See this shoulder joint on the right, how it's got all these muscles around it. So when this shoulder joint on the right subluxes, all of these muscles get pulled in the back, in the front. That's called the rotator cuff group. And that's where the pain is from. Same thing here, when the joints in the back, in the spine sublux, or when they shift around, then the muscles around the spine start to tighten up. And that's where they get their most pain from. So I just wanted to caution that because it may look like the pain is from the muscle, oh, you've got a muscle spasm, let's treat that, let's give you some muscle relaxants, or let's do some magical treatment to release the muscle. Bad idea. Bad idea. Your muscles are trying to protect you. Don't take away that protection. The treatment is to stabilize the spine. The treatment is to stabilize the joint, and the muscles are going to be happier and they will stop spasming. Pain in the arms. There are lots of reasons for having pain in the arms. Shoulder joint subluxation, dislocation, thoracic outlet syndrome, tendinitis, hyperextension, pain from the wrist and fingers. Let me go through each one of these. We talked about how the shoulder joint laxity can cause muscle spasms, and muscle spasms then cause more pain. But there is something called thoracic outlet syndrome. And it is extremely common in patients with the EDS. So in my experience, I've had about 20 years of experience in treating EDS. So in my experience, I think there are two kinds of patients with thoracic outlet syndrome. A majority of them don't need treatment. It's not a big problem, but there are a small subset that do need treatment. Let me explain to you. So these patients with thoracic outlet syndrome present exactly as if they are pain coming from their neck. So it goes down their arm, it's into specific fingers, nerve distribution, and it looks almost like there's something wrong with their neck, and that's why they have this pain. But if you notice carefully, there is no neck pain. So it's really important. Thoracic outlet patients do not complain of neck pain. They'll complain of pain down the arm, but if you ask carefully, they don't have any neck pain. What happens? So this is a kind of a busy slide, but let me show you. This is the first rib. So this is the first rib right here, and across the first rib is the collarbone right here. And between the collarbone and the first rib are nerves that travel down the arm. So these are the nerves that travel down the arm. And what happens is if the shoulder joint is loose or lax, then the collarbone bumps down onto the first rib. And when it bumps down onto the first rib, it compresses the nerves that are going down your arm. And that's how they feel that pain. And this is called thoracic outlet syndrome. The reason I'm bringing this up is because oftentimes patients are told, patients with EDS are told, oh, you know what, this pain that's coming down from your arm is coming from your neck, and you need a disc surgery or something like that. But I just want to caution them that it may not be from the neck. It may be more from the thoracic outlet syndrome. The treatment for thoracic outlet is, in most cases, if it's minor, I say don't do anything, leave it alone. If it's not bothering you, it might cause some tingling in your hand, but just leave it alone. But you can try some exercises. They have something called thoracic outlet exercises. They can do kinesiotaping. Botox injections work extremely well in these cases. If all else fails, it is surgery. And it's not a fun surgery. And so I really don't, I think I may have had only about 10 cases where patients had to have surgery, but most of them do fine with Botox injections, and most of them actually do with nothing. Hands and wrists. One of the things that EDSs have is poor joint position sense or poor proprioception. That means their brain doesn't know exactly where their joints are. So they tend to hold things very tightly. So they hold their pen super tightly. When they write, they press hard. What happens is that the muscles, the small muscles in their hand get tired. On top of that, they have loose finger joints. And mine are not loose, but they have really loose fingers. So it's like having jello fingers. Now to hold anything, for example, if I have to hold this bottle, I have to stiffen my fingers and grab this bottle. Because if my fingers are all loose and lax, then it would be really hard for me to hold this bottle. I will need more strength, more energy to hold this bottle. So in general, because of poor joint position sense and because of laxity of the finger joints, these patients tend to use their muscles a lot. And so they have hand pain a lot. The treatment for that is one for those with pens and pencils. So kids who use them can use a thick foam wrapping around it. It's sold as, there's a company called Abelware. I believe you can find it on Amazon, or you can just wrap foam tape around their pen, toothbrush, forks, knives. They can use compression half finger gloves. So fingerless compression gloves work very well. They're sold as arthritis gloves, and you can find them there. For those people who have very, very loose, lax fingers, they can use ring splints. So these are ring splints. They're made of metal. They're also sold in plastic. Please do not use the plastic ones because they deform. Metal ones work very well, and there are many people who make them at home actually. For my patients, I tell them to just go on Etsy and they can find it there. On Etsy, there are quite a few people who are making these. There are some EDSers who are also in support groups. You can look for them. They do a really good job of making these finger splints. And these are they work very well. They help stiffen out the fingers. If you're not sure which ones to use, I would recommend using it for these three, the thumb and these two fingers, because these are the ones you use the most. So let's talk about splinting and bracing in general. So bracing maintains your joint in a neutral position. So imagine this is your knee joint. This is the normal knee joint. In EDS, you're going to see the knee joint as hyperextended. So it brings the knee joint into a neutral position. They help with joint position sense. And it's a good idea to start. They prevent hyperextension. Generally, I recommend start using them slowly. And then once you've gained strength, then you can stop using them as slowly as another way to do it. Oftentimes, we get this feedback saying, oh, there are providers who say, physicians, medical professionals who say, oh, don't use braces, they make your muscles weaker. And that actually is not true at all. Number one, braces do not cover muscles. They cover only joints. So in fact, if anything, braces make your muscles stronger because it stabilizes your joints. Once it stabilizes your joints, you tend to move your muscles more. And so you move your joints more efficiently. And so it actually strengthens your muscles more. Let's talk about knees. Actually, before I do that, let me explain to you something. In the lower extremity, if your if your ankles and your feet are not stable, then unstable ankles and unstable feet can make your knees unstable. And oftentimes, EDSs have unstable knees to start with, which then makes their hips unstable, which then throws their back off. So everything starts at the bottom here. Unstable ankles make unstable knees, which make unstable hips, which make unstable SI joint, unstable spine. It's like a Jenga tower, unstable Jenga tower. So I'm going to go straight to the feet and ankles. So you can see over here, you can see this is flat feet. This patient has flat feet. This is the way how podiatrists diagnose flat feet. They just look at it from the side. The one thing I wanted to point out was, it's not in this picture, but generally the flatness is also in the front. So their toes splay out. So if ever you buy shoes, make sure you buy wide shoes. Flat feet can also cause pronation of the ankles. So you can see how this ankle is turned inwards. And that throws the entire balance of the body off. So correcting flat feet becomes really important because it helps maintain your balance better over here. Shoes, extremely important to wear proper shoes because they help with unstable ankles. They help with hypermobile feet. It should have a cushioned midsole. Make sure that your shoes have laces. So if this is your shoe, this is your foot, your shoe should grip your foot. So it should have laces. Don't wear slip-ons. For people with unstable ankles, I recommend high-top shoes. Let me show you what a high-top shoe looks like. These are high-top shoes. So what they do is, and as you can see, they all have laces. They maintain the stability of your ankle joints. This shoe is by a company called Asics, and this one is a company called Doc Martens. For flat feet, I recommend using shoe inserts or orthotics. Orthotics, they're very easy to find. Most pharmacies sell them. A standard orthotic, make sure that it is made of firm material, make sure that it has a nice arch. The company that I like to use for orthotics is called PEDAG, P-E-D-A-G. It's a German company. You can actually buy it online, you can buy it on Amazon, and they make really nice shoe inserts. But pretty much any shoe insert will do the job. The reason you need a shoe insert is because you want to avoid this pronation over here. Knees. So moving up to the knees, so one of the things that's usually unstable in knees is a hypermobile kneecap. And as you can see, the patella swings from left to right over here. They also have hyperextension of their knees. If this is the normal knee, their knees often go backwards. And this can cause pain in the thighs, it can cause pain in the knees, and even go up to the lower back. This is what a hyperextension of the knees look like. So this is, on the left is a normal knee. And you can see how the force of the body, the weight of the body goes right through the knee. But if your knee is backwards, if it's hyperextended, then the weight is not going through the knee. It's going straight to the ankle joint. And that's the problem. So oftentimes ankle joint pain is because of an hyperextended knee. The treatment for knee pain or of unstable knees is to use a knee brace. The recommendation, so this is a standard knee brace. This is actually made by a company called Bauer. It's a German company. It should have 2 straps on the top. It should have 2 straps on the bottom. It should have a little donut over here. This donut here, that should keep the kneecap in place. This is a strap on top. This is a strap on the bottom. And then there's a metal hinge over here inside that keeps the knee from hyperextending too much. So it brings the knee back. Another common cause of pain, and actually this is a very common cause of pain in the legs, is, I'm going to show you over here on a picture. There's a joint near the knee called the proximal tibiofibular joint. This joint becomes unstable. This joint usually becomes unstable is if they have an ankle instability. Because the ankle becomes unstable and it rolls, it causes this joint to become unstable, which then pinches this nerve. This is called a peroneal nerve. And this nerve is responsible, it causes pain on the side of the leg. It also causes drop foot. So patients tend to trip over their toes. One of the concepts in EDS is called joint position sense, which is also known as proprioception. Let me explain to you how proprioception. So imagine somebody's walking. Imagine somebody's walking. They lift up their right leg. The brain knows exactly where the right foot is. And so it sends a message to your left leg how to balance it. And then you bring the right foot down, you lift the left leg up, and your brain knows exactly where the left foot is, and it helps balance the right leg. So essentially, there are sensors in our joints that tell the brain exactly where all the joints are. For example, if I need to scratch my head, I can scratch it without looking at anything because my brain knows exactly where my knuckles are, and I can zero in on my itch. That's called joint position sense, also known as proprioception. Proprioception, people with joint problems lose proprioception. For example, the elderly, because of joint arthritis and joint issues, they tend to lose joint position sense, so they tend to fall a lot. Athletes lose joint position sense. They damage their joints a lot. So this is a common situation. Obviously in ADS, because there are so many joint issues, so they tend to have very poor joint position sense. And that is a reason why EDSers tend to walk into doorways, tend to walk into furniture, tend to drop things, is because of poor joint position sense. One of the ways to help with joint position sense is to wear something that is skin tight. So what the brain does is that when it's not getting a message, say for example, in this case, when it's not getting any signal from the knee, it uses contact with skin, the fabric in contact with the skin, as a way to figure out where the knee joint is. And that helps the brain understand where your, helps you protect your body. It helps with understanding joint position sense. So wearing skin tight clothes does make a difference in patients with EDS. And that is also the same principle why exercising in water helps a lot, because the pressure of the water sort of gives patients a better sense of their joints and they can exercise their joints better. It also takes the load off their joints. And so they don't have to strain their joints when they exercise. I'm going to touch very quickly on POTS, or also known as dysautonomia. What happens in POTS is patients with POTS present with fainting, dizziness, heart racing or palpitations, fatigue, headaches, cold hands and feet. They have brain fog, and they have this constant sense of anxiety. Now, what happens in POTS, the reason people with EDS have POTS is because when we stand, we pull all our blood down our legs. And right away, the nervous system kicks in and pumps this blood back up to the brain. That's what happens normally. It happens in EDS also, but the problem in EDS is that they tend to pool more blood. And because they pool more blood, their nervous system has to work extra hard to pump this blood back up to their brain. And so their nervous system is always working hard. And this is the same nervous system that controls flight and fight. So their heart is always working harder. They always have this sense of flight or fight, also known as anxiety, all the time. Because they have poor blood flow to their brain, they have brain fog, they have fatigue, and those are the symptoms of POTS. This is a whole this was a whole presentation by itself, but I just want to briefly touch on this because it does affect functioning. The simplest way to manage POTS is to increase your salt. As long as your blood pressure is low, increase your salt. Go for salty foods. Some people even wind up taking salt pills. Increase your electrolyte fluids. So you should be having at least 64 ounces of fluids a day. I'm sorry, we don't use metric systems, but you can convert it. It's 64 ounces of fluid a day, of which 16 ounces, which is 1 commuter cup size, should be electrolyte fluids. And you can buy there are lots of electrolyte fluids and electrolyte powders sold in the market that you can add to the water. They do need to wear compression pants that go up to the thighs. So that prevents pooling of blood. This is a very brief management of POTS. There are many other things that need to be done, but because of time, I just wanted to quickly touch on that. One other thing I want to talk to you about was mast cell activation syndrome. This is a painful condition. It's like having flu all the time. You're tired, you're cold, you're sick, you don't have any appetite. It adds to your fatigue. It causes loss of appetite. What happens in mast cells is, so we have cells in our blood called mast cells. And this is what a mast cell looks like. Mast cells are normally inactive. And when the body senses a threat, when the body senses something's wrong, it activates these mast cells. And when these mast cells get activated, they release these mediators. They release chemicals. These are the list. There are over 200 of these, but I just mentioned a few of them here. They release these chemicals that help protect the body. It's part of your immune system. But the ones that I really wanted to focus on were the cytokines and histamine. And so your body starts to produce a ton of histamine. It produces a lot of cytokines. Think of cytokines as text messages that send out a text message saying pain. And that's how your body starts to feel pain. These are the symptoms of mast cell activation syndrome. It can affect your brain. It can cause brain fog, headache, dizziness, confusion. As you can see, it's pretty much similar to POTS. It can cause palpitations, dizziness, fainting. It can cause GI issues like abdominal pain, nausea. It can cause bladder issues, bladder cramping, bladder pain. It can cause wheezing sensation in the lungs. It can cause joint and muscle pain. So these are a few of the symptoms of mast cell activation syndrome. Think of mast cell activation syndrome as something that causes inflammation in the entire body. So everything hurts. The treatment, this is very briefly, again, the treatment for mast cell is to start with antihistamines like famotidine and Benadryl. Mast cell stabilizers like quercetin, ketotifen, and cromolyn. Avoid triggers that can trigger your mast cells like foods, and look at the air quality. There are some foods like seasonings, meats, grains, gluten can trigger mast cells. If there's mold in the house, if there's pollen, there's dust and all, some of these things can also trigger. Smells can trigger. In some cases, going out in the sun can also trigger your mast cells. Fatigue in EDS is a very big issue. It's very common in EDS. There are many, many reasons. So what I've done is I've summarized them. EDS itself can cause fatigue, POTS can cause fatigue, mast cell activation syndrome cause fatigues. Some of the medicines used to treat some of these conditions also cause tiredness. Pain can cause fatigue. Poor sleep is very common. They have what is called sleep inversion. They don't sleep at night, but sleep during the day. And then this secondary mitochondrial dysfunction can also be seen in these conditions. Mitochondria are like rechargeable batteries in our body. And what happens is that these rechargeable batteries are not working as well. So they tend to not have enough energy. Their batteries are not storing enough energy. So this is there was a lot of interest in low-dose naltrexone, also known as LDN. LDN came into use for EDS about 10, 15 years ago. I started using LDN first for the treatment of neuropathic pain, nerve pain, CRPS. That was back 20 years ago. And then there were some patients that I had who had both EDS and CRPS. So I was giving them LDN, and I found out that it was also improving some of their EDS symptoms. And so I started using them for EDS, and then it started educating other physicians about it. And so it has picked up from then. And now I can see it's becoming more and more popular. So this part of my talk is a little more scientific. So what happens is naltrexone is a very old drug. It's been around for almost 30 years. It was originally invented to treat something which I'm hoping none of you have, is heroin and alcohol addiction. What it does is it works as an antagonist. That means it blocks mu and kappa receptors. These are receptors, keyholes on which morphine works on. So it blocks where morphine works on. It is also converted by the body into something called 6-beta naltrexone, which also acts a little bit like naltrexone. Naltrexone's half-life in the body is about 6 hours. That means that in 24 hours, in 24 hours, any naltrexone that you take is gone from your body. But the half-life of 6-beta naltrexone is 13 hours, which again, in 52 hours, the rest of it is gone. So generally, we consider that naltrexone is fully eliminated in 24 hours. The problem is that naltrexone that you get in the market and by pharmaceutical companies is about 50 to 150 milligrams. Low-dose naltrexone, but LDN is between 1.75 to 4.5 milligrams. So as you can see, it's a really, really, really tiny dose. And I'll get to it. Why are we using such a tiny dose? So what happens is that naltrexone tricks the body in producing more endorphins. It blocks the receptors, it blocks the keyholes where morphine acts or where your endorphins act. It blocks those receptors for a very quick while because it's such a tiny quantity. It blocks it very transiently. So the brain thinks that, oh my goodness, we need to produce more endorphins because it's the receptors are blocked. So your brain starts to produce more endorphins, which are also known as endogenous opioids or endorphins. So the levels of endorphin and enkephalin are raised persistently. So you are getting a runner's high by just taking a pill. That's the trick here. The key point I want to make over here is two things to remember. It should be taken only once a day, not more than once a day. It also should be taken in a small dose. The normal dose is about 4.5 milligrams. Some physicians can actually go up to 6 milligrams, which is fine, but it has to be a low dose, and it has to, because you only wanted to block a few of the receptors. And it should be, so 6 milligrams is about the right, 4.5 to 6 milligrams is the right dose. And it should be only taken once a day. Whether you take it in the morning or whether you take it at night is your choice. So when we produce more endorphins, it promotes healing. Remember we talked about microtrauma, how people with EDS tend to damage their tissue so much, and it takes a long time to heal. That's where the LDN helps. It promotes healing. It inhibits cell growth. Some cells are inhibited. It reduces inflammation. So there is something called OGF, otherwise known as opioid growth factor. It's a type of an endorphin. It has this fancy name called MET5 enkephalin. Opioid growth factors are also endogenous pentapeptide. That means these are produced by the body. It's a protein that's produced by the body. When your body produces opioid growth factor, it stimulates a receptor called opioid growth factor receptor. Now, the combination of opioid growth factor and opioid growth factor receptor regulates cell growth in normal and abnormal cells. LDN blocks opioid receptors intermittently. So this intermittent block increases production of this combination of opioid growth factor and opioid growth factor receptor by a positive biofeedback loop, which means it increases the number and density of opioid growth factors receptors. I'm sorry, this is very, very scientific. I'm hoping this is good for the providers in the group, but I promise I'll get down to more regular English in a few minutes. We have in our brain called glial cells. And these glial cells, in fact, 70% of our brain is made up of glial cells. So 70 to 80% are part of the glial cells. They are responsible for immune surveillance. That means they do all the janitorial work in our brain, and they also protect our brain cells. The problem is that when these glial cells get activated, when they get angry, they produce cytokines. And I remember I told you cytokines are text messages that send messages saying pain. So when they produce inflammatory chemicals that cause the nerves in the brain and the spinal cord to become inflamed. Shelf that to the one side. There's something called toll-like receptors, or TLR. There are many types of toll-like receptors. These are a class of proteins that are responsible for our immune system, and they're produced by macrophages. When there's an infection or when there's a threat to the body, these toll-like receptors activate the immune system. And one of the toll-like receptors is called TLR4. It is produced by these glial cells, and these glial cells upregulate, they're upregulated under neuroinflammation. That means if there's any nerve inflammation, there are more toll-like receptors produced by these glial cells. Opioids cause glial cell activation by acting on these receptors, which then produce more cytokines. And that's where the LDN comes in. It blocks these opioid, it blocks TLR4 signaling. That means it prevents the TLR4 receptors from being produced. So in summary, about the, if I've not confused you enough, this is a summary slide. What happens is that low-dose naltrexone should be taken once a day. The dose is anywhere from 1 milligram to 4.5 to 6 milligrams. Some people with EDS are extremely sensitive to LDN, and if they find that they're having a reaction at 4.5 milligrams, we drop them down to 0.5 milligrams and then slowly increase from there. But mostly it is about 4.5 to 6 milligrams taken once a day. So it increases your production of endorphins. It upregulates the OGF axis. It decreases production of cytokines and neuroinflammation. The side effects of LDN are very transient. They are very temporary. Some people have headaches. They may have insomnia, which is why in my patients, I usually start it in the morning. Sometimes they may have colorful dreams. So they get to see a free movie, but these are transient. They go away after some time. So after a few days, they go away. If they don't go away at 4.5 milligrams, you can drop the dose to 2 milligrams and then go up again. The general recommendation, LDN is not a drug that you're going to see an effect right away. It takes time. You have to give it a few weeks. Most physicians who use LDN over here recommend trying it for at least 6 months. And it's amazing. I was told before this presentation that insurance companies in Israel actually pay for LDN. Insurance companies in the United States don't pay for LDN. It's not. It's actually not as expensive, but it doesn't cover LDN. So this is my last slide. I just wanted to connect the dots. People, you can have fatigue from a combination of EDS, POTS, and mast cell. Diffuse pain can also be from all of these three. Headaches can be from EDS, POTS, mast cell, tethered cord, Chiari malformation. Joint pains can be from EDS and tethered cord. Dizziness can be from POTS, Chiari malformation. Even mast cell can do that. Poor balance is from all of these conditions. GI issues can be from EDS, POTS, and mast cell. That feeling of anxiety happens with POTS mostly, but sometimes in mast cell. Just want to point out that mast cell activation syndrome can actually trigger POTS also. And so with this, I should end my presentation. Thank you.
Thank you so much, Dr. Chopra. Such an informative talk, full of solutions and new information to many of us. Thank you.
You're welcome. My pleasure.
So people do have various questions. We will start with questions regarding the LDN treatment. And first of all, is there some kind of written protocol or a reference for LDN treatment that we can give our doctors for them to see?
I did. So in 2012, I published a small paper. It was a case, 2 cases where I talked about LDN. And that was well accepted. But since then, there have been a lot of medical literature. The best place to get all this information is on a website called LDN Research Trust.
Yes.
That's where you found me actually, and that so it's a non-profit organization from UK, and there's a ton of information, and they have all the papers that you want. They're all there for your physicians.
Okay, very important. Einat, next question maybe?
That's next to me, okay. I have a question. Patients are thinking that LDN may cure POTS. Do you know anything about it?
No, I'm sorry, it doesn't fix POTS, but we are getting some reports that it can help mast cell activation syndrome. We don't have any proof yet, but a lot of the physicians who treat EDS and all these issues are seeing that it can, you know, one of the things that LDN does is it stabilizes the immune system. And so, excuse me. So one of the things, like I just told you, mast cell activation syndrome can make POTS worse. So if you control your mast cell activation syndrome with LDN, then it may bring the POTS down. But I have never come across it actually helping POTS directly. But there are some patients with POTS. There are some patients who have POTS because they have an autoimmune dysfunction. And if it is because of an autoimmune dysfunction, then the LDN may help. But I don't want to say that this is a magical treatment for POTS. This is one of the many things that you can use to help with POTS.
Okay, thanks.
Good, great to know. Next question is how, if possible, to combine LDN and opioids if necessary?
All right, so obviously, in theory, it does not make sense because you're trying to block the opioid receptors, but then you're also taking opioids. It doesn't make sense. But one of the things that over the years, when we first started, we were all very nervous and we told all our patients, don't take any opioids at all when you're taking LDN. But over the years, most of us have discovered that a small dose of opioid here and there will not be a problem. For example, I'll give you an example. Somebody is on LDN and is not taking opioids at all and has an acute flare-up of their pain. It's really, really bad. So much so that they need to go to the emergency room and the pain is so bad. They can take a pill of an opioid, short-acting opioid, and it won't do any harm. We generally recommend waiting for about 6 hours before you do that. 6 hours after taking the LDN. So you wait for 6 hours after LDN, you take the opioid, but taking it once in a while, not always. And definitely not taking a long-acting opioid. But what if somebody is on LDN and gets into a car accident and now has to be rushed to the emergency and they need to give the person, has a broken femur? In that case, they can be given anything they want. It won't make a difference. It'll still work. So if they give them any morphine or something, it'll still work.
Okay.
Okay, so next question is medication protocol for neuropathic pain with EDS, like small fiber neuropathy, tetracord. What would you recommend?
Well, that is a very long, that's a very lengthy answer to that question. So tethered cord and small fiber neuropathy are two different animals. And I look at small fiber neuropathy as something like your hair turning gray. As we grow older, the nerves, the smaller nerves in our feet start to kind of die. But if you have an autoimmune condition, then that can happen earlier in life and it becomes severely painful. Normally, a bad small fiber neuropathy, a painful small fiber neuropathy is an indication of an autoimmune dysfunction. In that case, they need much more drastic treatment, like what are called immune modulators, like IVIG and all of those drugs. But for tethered cord syndrome, if they have pain because of tethered cord syndrome, then the treatment is surgery. So mechanical problems need mechanical solutions. Chemical problems need chemical solutions. If your spinal cord is tethered, no amount of medicine is going to help it, other than doing surgery to it, to release it. Chemical problems that are causing the small fibers to die because of an autoimmune dysfunction will need chemical solutions like immune modulators, like IVIG and all of those.
Okay. Next question we have is, can LDN be used for many years? Are there any long-term adverse reactions, and can the body get used to it and therefore reduce the effect?
Which drug?
LDN.
Oh, no. We haven't seen any long-term side effects, not at all. Remember, when the FDA in the United States approves a drug, one of the conditions that they put on the company is that they are going to monitor the drug for the next 20 years to make sure that there are no other things that show up later on. And the drug has been around for 30 years and no long-term effects have been seen from 150 milligrams of naltrexone per day. We are taking a teeny tiny dose of 4.5 milligrams. There are no long-term side effects that have been seen. And it can be taken forever. You don't get used to it. It's not an opioid. It's not an addicting drug or something. And you don't get used to it. Not at all.
Perfect. I take it for 4 years, so.
Yeah, there you go.
Yeah. Next question is about the combination of medical cannabis and or CBD with LDN. Can you combine the treatments?
Okay. You know, I had put my slides for cannabis and then I took it away because I wasn't sure if it's approved in Israel. But
it is.
That's fantastic, because one thing about EDS is that people with EDS, for some reason, do not respond to opioids well at all, but they respond very well to cannabis. And it does not, you can take LDN with cannabis. There is absolutely no interaction. It's perfectly fine. In fact, I don't even think that cannabis reacts with any medicine that we know of. It is so safe to take it. But in EDS, I would recommend for pain to take a 1-to-1 ratio of CBD and THC. You should have at least 1-to-1 or approximately that much. That helps a lot.
Okay. There's a question regarding when in the day to take LDN. You've mentioned it, but the question reads, you've stated that LDN could be taken anytime during the day. However, some places or websites state that it's better to take it during the night, since endorphins for each day are always produced in the pre-dawn hours, regardless of the hours when one is awake or sleeping. So if you could answer this.
Yes, I can. And that is a really good question. So one of the first persons to do some research on low-dose naltrexone was Dr. Barnard Bihari in New York. And this was during the HIV epidemic era. And at that time, they were not sure, how LDN is going to work, whether it's going to help or not. And so they figured that, we should give it at night, because at around 2 o'clock in the morning is when we produce our most endorphins. So giving it at 10 o'clock at night would be the best way for it to work. But over the years, it has been shown that it doesn't matter what time you take it. And So yes, you can take it at 10 o'clock if it's not a problem. Most of my patients take it in the morning, and I tell them it's your choice, but either the morning or the evening, it should be only once a day. So it's not, there's no such thing as that you have to take it at 10 p.m. and it'll work better. There's no such evidence we have. It was a long, long time when it first came out in the 1960s. That was one of the theories, but now it doesn't matter.
Great, I think you made someone very calm right now. The next question is about the treatment you would recommend for EDS along with CRPS together.
Whoa. That is a hard one because CRPS by itself is a very complex condition. Now, and I do treat CRPS and I do treat EDS, and that's actually how I started getting into EDS, because a lot of my younger patients that I was seeing with CRPS were coming in with EDS also. And the problem with EDS is that there is sometimes this overstretching of the nerves, and or there's impingement of the nerves. For example, in thoracic outlet syndrome, the nerve is getting pinched over here. And so these patients can present with symptoms of CRPS. And like I told you before, that the treatment of pain lies in finding the cause of the pain and treating it. So if there is any impingement of a nerve, like in thoracic outlet syndrome, or there's an impingement of the nerve on the leg, where I talked about the peroneal nerve, then fixing that would help with CRPS. But for people who have CRPS, generally in most cases with EDS and CRPS, there's always a reason that you can find out why these people have CRPS. There is something that is not right that is causing the CRPS, and that is the best way to treat it. Other than that, is just use the usual medicines for CRPS and you know, try that. But I would recommend this person to definitely look for what's causing the CRPS. There is some nerve that is being pinched or overstretched.
Mm-hmm.
That's the thing.
Okay, next question. For your point of view, what is the role of physiotherapy in pain treatment?
Okay, so physiotherapy. So again, physiotherapy is great, but the physiotherapist has to understand the issues with EDS. And so, you know, there are very few physiotherapists in the US who actually understand the problems of EDS. And so what we do is, I tell patients that if you don't have a physiotherapist who understands EDS well, I'd rather you not do physiotherapy at all and just do your exercises by yourself. But I'm hoping there are some physiotherapists on this panel here. The things to remember in physiotherapy is that the tissue is very friable. It's weak. It can break down easily. So that philosophy of no pain, no gain does not work here. Number two, always keep under your range of motion. For example, if I can bring my elbow out here, stop right there. If I can bring my arm here, stop short. So always stay under your range of motion because you don't want to overstretch your ligaments. The next thing is stay under your tolerance of exercise. For example, I can do 20 reps of, say, bicep curls. Then just do 6 or 8 or 10 bicep curls. Don't do 20. Good day, stay at 6. Bad day, stay at 6. We are not trying to do we're not going into any muscle building competition here. So the idea is to keep the muscle strong without damaging the muscle, without damaging the joint. So these are some of the principles of physiotherapy. The other principle on physiotherapy that they should follow is people who have POTS or really severe POTS should exercise lying down. And actually, if you go on YouTube, there are some really good exercises on exercises for patients with POTS. Lying down, you do them lying down, or reclining. You can do that too. The other set of exercises that patients with EDS should do is they're for joint position sense or proprioception. Those are the fun ones, like stand-up paddleboard, sitting on an exercise ball, or there's something called slacklining, which is you walk on a tape between two trees, you walk on the tape. These are some of the balance exercises. Wobble board is a very good exercise for EDS. But be careful, in POTS, all the exercises have to be done lying down. That's the main thing. And always stay under your limit. If your limit is 20 reps and you do 19 reps, then you will not be able to exercise for the next 2 weeks. And it's a waste. So you do only 6 reps so that you can exercise again the next day.
The importance of pacing, I think many of us know this.
Yeah.
Yes, pacing is
Very
very
well.
good.
I think,
It's called, you know, the spoon theory, right? It's called the spoon theory.
of course.
Keep some spoons. Don't use up all your spoons. Keep some of them.
Definitely. I think we have time for one more question, and if it's okay with you.
Sure.
I think this is a very important one. How do you know if a subluxation or dislocation has caused a tear in a ligament or a muscle or a tendon, or the pain is due to spasm?
Okay, so supposing someone has, generally in subluxation, let me explain. It's not, so in subluxation or in a dislocation, when you put the joint back, the pain should go away immediately, or it should become a lot less. So if, for example, my shoulder subluxes, my pain will shoot up to 10. As soon as I put my shoulder back in place, it'll drop down to 2. But if I have torn my capsule or damaged my tendon, then that pain will still stay up there. It may not be as bad as 10, but it'll still stay at like 7 or 8. It'll still be pretty bad. And oftentimes when you check the tendon or the ligament, they can find out if it's torn or damaged.
Mm-hmm.
There's a second part to that question, I forgot.
How to tell if it's a torn something or a muscle spasm?
Oh, oh yeah, right. So, well, a spasm is easy because if you feel or somebody else feels that muscle, they'll feel the muscle knots. They'll feel muscle knots. There'll be tender spots over there, and they can feel the tightness. But if it's a tear, then it's very difficult to figure that out clinically. Then you need to get either an X-ray or, no, I'm sorry, not an X-ray, an MRI to look for the tear.
Mm-hmm. Okay.
It's very difficult.
Okay, I think this is all the time we have for questions. Dr. Chopra, I want to thank you again enormously for this so enriching and informative talk, and it just stresses how EDS is such a complex medical situation for us, for the physicians and therapists that treat us.
There is a book that just got published called Disjointed.
Hmm.
It's on Amazon. I think you can buy an electronic version also. And that has some really good information in it.
Okay.
Good to know.
Thank you very much. It was a pleasure and an honor to be invited to talk to you guys.
Thank you so much.
You're welcome. All
Good
right.
night.
You're welcome. Good night.
Thank
Good
you.
night.
Bye-bye.
Bye.